The following episode is brought to you by the American Urological Association. This special episode comes to you from the AUA Update Series, Volume 45. In this episode, we will be covering some of the key lesson points with Dr. Sarah Psutka, one of the authors of Lesson 1, The Role of Nephrectomy in Advanced Kidney Cancer. The AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology. For more information or to unlock your own subscription to the AUA Update Series, please visit the new and improved AUA University at cme.auanet.org.
Hello and welcome to another episode of AUA University Podcast, where we explore important topics that shape urologic practice through expert discussion and evidence-based insight. I'm your host, Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today we're focusing on the role of nephrectomy in advanced kidney cancer. This is a topic that has evolved dramatically over the last decade, and frankly, it's one that still generates debate in tumor boards every week. To help us navigate this, I'm joined by Dr. Sarah Psutka. Dr. Psutka is an associate professor of urology at the University of Washington Fred Hutchinson Cancer Center and a leader in urologic oncology, outcomes research, and multidisciplinary care. She brings a pragmatic, evidence-driven perspective to some of the most complex surgical decisions we face in urologic oncology, and she served as the content expert for the Update Series lesson on this subject. Sarah, welcome to the podcast today.
Thank you so much for having me, Mark. It's an absolute pleasure to be here.
So we'll begin by referencing the Update Series lesson on this subject, and we note that the lesson opens up with a detailed comparison of prognostic scoring systems, MSKCC, IMDC, MDACC, et cetera, but some clinicians may ask, why does this still matter in the era of immunotherapy?
Well, I think that's the key question here. The approach towards the surgical management of locally advanced kidney cancer has changed so drastically over the past 10 years because we now have systemic therapies that are much more effective than anything we had. And I would say during my time in practice and my time in training, the face of this disease is completely different. There obviously is, as you said, a tremendous amount of debate about where surgery now fits in, especially in the setting of metastatic kidney cancer. And so a lot of these risk stratification factors have been developed to help us try to understand how are patients going to do specifically with specific treatments. I think the value of all of these different risk prognostication systems is that they help us to figure out the should, right? We know we can do surgery on a lot of these patients. The big question that we're all grappling with in these multidisciplinary tumor boards is the should. And these prognostic systems have been developed to try to help us inform that. But now that there are so many of them, the question is, which do we use and when? And that's what we tried to start to get to the bottom of at the beginning of this update system.
Yeah, and it's important, you reference prognostic models, and really, I think in some ways they serve as decision frameworks, right? To point out whether nephrectomy is considered at all, timing, right, relative to systemic therapy, and of course, patient counseling and expectations. When you look at all of what's available, what mistakes do you see, or perhaps challenges do you see when the clinicians use risk models perhaps too rigidly?
Well, I think the biggest challenge is using them in a situation in which they were not developed. And that's actually sort of the challenge that many of us have right now is we are applying, for example, the MSKCC and the IMDC risk stratification scores, which were developed for patients with metastatic disease to help to predict individual estimations of survival. But they weren't necessarily developed to tell us whether or not we should do surgery on somebody. And a lot of the times, those risk prognostication models are certainly used to risk stratify patients within clinical trial scenarios or even to to define the eligibility criteria for specific clinical trials. But we're now applying them as surgeons to help us understand what's the likelihood that I should put this person through, I should offer this patient a cytoreductive nephrectomy or a radical nephrectomy with lymph node dissection. That's where, for example, the screen criteria, which have recently been established and developed and validated as in a multi-institution cohort for patients who have had surgery, that's where a tool like that becomes very helpful, because that specific tool, as we get into in the update, was developed to help us understand the risks of putting that patient through the surgery. And so again, I think, to answer your question, you've got to use the risk prognostication tool for the reason that it was developed. One of the biggest challenges we see comes when we start to apply, for example, the MSKCC risk prognostication score, which was developed in the cytokine era, or the IMDC risk prognostication score, which was developed in the tyrosine kinase treatment era. We apply those now, where we are using combinations of either IO and TKIs, or IO and novel therapeutics that are leveraging completely different pathways, or even IO-IO. We're now extrapolating outcomes that were using scoring systems that were developed on completely different patient populations and have not necessarily been validated in the contemporary, using the contemporary therapies. So it becomes very complicated. And I think that when it comes to making treatment decisions based on that, we sometimes wind up making decisions that may not reflect the patient population that's in front of us.
Yeah, no, I think that's a very important point. It actually was answering a question that I was going to reference in terms of not just trainees, but even physicians who have been in practice for many years, when it comes to, which models should they choose, right? Which model should be applied? And I think it's very important to highlight that every model has its nuances and was, potentially developed in a different era. Now, there's this table in the lesson, and it doesn't just compare variables. I think it can quietly explain why, for example, two reasonable urologists might reach different conclusions for the same patient. And so I think, I think there are just a lot of details for which we can learn and potentially apply to the patients we're treating.
Yeah, I think one of the other nuances that hopefully comes out in the lesson, and I think something that we tried to package and make as simplified as possible, which is not exactly easy, is that these models all take into account different risk factors. Because again, they were developed in different patient populations when certain data points are available or not available. When it comes down to looking at the patient in front of you, you have to think about, when you are attempting to assess the specific patient and their overall risk for a specific outcome. Is the outcome toxicity from surgery? Is the outcome toxicity from systemic therapy? These models, again, are predicting different things. You also have to think about what data you've got. So, for example, it's really important. We tried to focus on models that are based on clinical staging factors that a physician's going to have in front of them. They're not going to necessarily always have specific, say, post-operative data that I would say if you look at a lot of the retrospective series that are out there, many times when people build multivariable models to assess the risk of a specific outcome, they incorporate a lot of the data we get from the actual surgery. So you then can't use those models, for example, to decide whether or not you should do the surgery to begin with. They're really helpful for providing an assessment to the patient after the fact of what their next steps are going to look like. So we tried to really get into what models you can use before surgery and afterwards to help patients understand what their trajectory is likely to look like. And I think there's also, we pointed to the fact that there's some disagreement about even sort of the specific definitions, like there's one of the debates that we're all having at a number of the meetings right now is, what is the definition of oligometastatic versus oligoprogressive? Where does surgery fit into those specific disease scenarios? So it is complicated, and definitions matter, especially when you are attempting to use these very strict risk prognostication models.
Right. Sarah, one of the most practical parts of the lesson is the treatment algorithm for patients presenting with metastatic renal cell carcinoma. Can you walk us through how this algorithm may reframe nephrectomy, not as a first step, but as perhaps a strategic decision point?
Absolutely. I think one of the things we tried to highlight in this series is that surgery remains an important part of the a piece of our approach to the management of advanced kidney cancer. But one of the things we have really learned, especially I'd say in the last 5 years, is that it's certainly not a uniform decision tree. And so we talk not only about really mapping and understanding the disease and the risk of the disease, but also understanding the likelihood that the patient is going to be able to withstand the stresses of the surgery. So we start with defining the comprehensive oncologic evaluation using best practices. But we then get into how one might approach a multidisciplinary evaluation and risk stratification, use and define when these different risk stratification tools can be helpful. I think one of the things we have clearly learned from what has largely been a large and evolving body of evidence that specifically is there's a number of multi-institutional cohorts that have been published just in the recent years that have tried to understand where surgery fits in with contemporary treatment, systemic treatment options, that supports that when you select patients well, those patients who undergo surgery, there seems to be an association with improved survival. Now, you can't say that's causal, right? Because there's tremendous impact of selection bias in there, because these were all, again, carefully selected patients by the treatment teams that were taking care of them. But we get into in which situations you might think about upfront cytoreductive nephrectomy versus a deferred cytoreductive nephrectomy, and also those patients who actually systemic therapy is really going to be the best option for them, and surgery should be deferred. One of the points that I think we tried to really bring up, though, is that this is going to be a dynamic process, because patients' fitness for surgery can also change as they go through therapy. And I think a lot of us have looked to systemic therapy, especially these highly effective, newer contemporary therapies, as strong litmus tests for the likelihood to understand how a patient is going to respond. And then the question is, when do you consider surgical consolidation? And now, of course, we didn't even get into all of the other opportunities for non-surgical consolidation, for example, of metastatic sites. So I think the treatment algorithm, one of the things we were trying to get at was there are very specific scenarios where we do think about upfront cytoreductive nephrectomy being really still the standard of care, as we thought back in the early 2000s in the cytokine era. But I would say the decision as to when you surgically consolidate someone who started on upfront systemic therapy, that actually is that's a decision we are confronted with often multiple times. And a patient who maybe at time point A is not thought to be a great candidate for surgery may become a better candidate for surgery with the second line therapy or third line therapy. So we tried to kind of get to that dynamic sort of state of decision making, and the fact that multidisciplinary care is really involved. Those multidisciplinary meetings around a single patient's treatment may have to happen multiple times. It's not just a one and done.
Right. You referenced the decision making that goes on as a patient has received potentially sequential treatments. What's the hardest branch point you think you would find in the algorithm, perhaps for you personally, when you're seeing a patient in a clinic? Is it the one you referenced most recently, or perhaps someplace else in the algorithm?
I think in my mind, there actually these days are relatively few patients with, let's say, metastatic disease, and that could be metastatic to the regional nodes or distant metastases, in whom upfront cytoreductive nephrectomy is clearly the right choice. Definitely, there are some patients where, that patient has a symptomatic primary tumor, And so you're thinking perhaps they have a paraneoplastic syndrome, or perhaps they are presenting with severe bleeding relating to the primary tumor, in whom you might, if they are well enough to withstand the stress of surgery, you might think about upfront cytoreductive nephrectomy as the right first choice. But I think it's interesting because a lot of our contemporary systemic therapies, they actually, for things like even bleeding, will reduce the symptoms related to the tumor pretty effectively. And given what we know about the efficacy of those therapies, it's enticing to try to give those patients as much systemic therapy and get as much benefit out of it upfront as you possibly can before thinking about surgical consolidation. So I think in terms of the most difficult branch point, I think it's actually making the jump that a person should go to surgery first. What I feel is really important and hopefully comes across in the lesson is that the nature of care for these patients is really multidisciplinary, but I think in practice, obviously, most of these patients follow with one of us. They follow with the surgeon or they follow with the medical oncologist. And I think what's important is to maintain the lines of communication so that whoever is in charge kind of is aware that there may need to be a warm handoff of that patient's care from medical oncology back to surgery at an appropriate time point, and to have kind of clear ideas of when those triggers for reinitiating that multidisciplinary conversation come up. And so we tried to be really clear about when during surveillance it might be a good idea for example, a medical oncologist to reach back out to a urologist and say, this patient's doing really well. They have absolute sort of stasis of the metastases, but we're starting to see growth in the primary. Is this a time when you would consider surgical consolidation? And I think just as an example, the other thing we did bring up is that time on systemic therapy can also be used to improve the surgical candidacy of a patient, essentially to prehabilitate them. And so there's a lot of opportunities for crosstalk, but you have to maintain those kind of multidisciplinary lines of communication.
Great points. And, the figure in some ways is deceptively simple, but once you study it closely, it can really serve as a mental checklist that can be potentially used every time we see a new patient with metastatic renal cell carcinoma. Going further into the lesson as we wrap up, it brings things to life, if you will, with case presentations, right, and imaging. Why were case-based examples essential for conveying or teaching this particular topic?
Well, I think this is a really complicated and nuanced disease space. And the fact of the matter is the current guidelines for which systemic therapies are offered to these different patients, that's changing so rapidly that we have multiple updates to, for example, the NCCN guidelines annually in terms of when you would choose which treatment combination as first line, second line, third line, and so on and so forth. We wanted to highlight some of the most common scenarios that urologists might find themselves confronted with. So just without giving too much away, because we want people to look at the lesson, but we wanted to highlight a great example of a patient who might be a good candidate for an upfront cytoreductive nephrectomy as standard frontline therapy. We highlighted a patient who, for example, might be more appropriate for upfront cytoreductive nephrectomy without metastatic disease. And I think, tumor thrombus squarely fits into this disease space. But there's a lot of, I would say, debate right now about when you take a patient with tumor thrombus to the operating room or not. And that is a very recent debate, especially with certain investigators starting to evaluate whether, for example, SBRT should be used for tumor thrombus, whether we should try to cytoreduce all patients with tumor thrombus in the absence of distant metastases. So we wanted to highlight some of the challenges there. And then the last case that we put in was a patient who had metastatic intermediate risk disease, who went through systemic therapy up front and then ultimately was surgically consolidated. And these are all patients of mine, actually. And that person is doing really, really well now, years after surgery, off therapy and remaining NED. So we wanted to kind of bring some of these decision trees to life and hopefully give people some examples that could help to understand how these would play out in real time with complex patients who have very complex past medical histories. But what highlight sort of the decision points and how we re-stratified the patients and why we made the decisions we did.
Yeah, I always think that case-based discussion and examples are, very important to help understand, the variability that can exist in the real world, and I find those very helpful. So, Sarah, this update series lesson actually does a remarkable job of helping clinicians rethink nephrectomy not as an isolated operation, but as part of an integrated multimodal treatment strategy, as you referenced. And to our listeners, thank you for joining us. For more educational content and resources, including the full AUA Update series, visit auanet.org/university. And to Dr. Psutka, we thank you for your expertise and insight into this evolving field. I'm Dr. Mark Gonzalgo. Thank you for joining us on AUA University Podcast. Stay informed, stay engaged, and continue advancing the science and practice of urology.